our presenter today. Amy Griffin is a supervisory public health analyst with Health Resources and Services Administration, otherwise known as HRSA, and she is in the HIV/AIDS Bureau. She's been serving people with HIV in varying capacities since 1991. Prior to her work with the HIV/AIDS Bureau, she worked as a national technical assistance provider for the Housing Opportunity for Persons with AIDS program, and some of you may know that as HOPWA, at the U.S. Department of Housing and Urban Development, and some of you may know that as HUD. It's all a big acronym in this field. We can speak a whole different language with acronyms only, right? In this presentation, Amy will outline the impact of unstable housing on the health outcomes of people with HIV and efforts being conducted to address it. And she's going to be focusing on a federal perspective and addressing the intersection between housing and HIV healthcare through collaboration, policy work, and funding. There will be time at the end for questions and answers. So please keep track of all of your questions as Amy presents. And we are hoping to have another presenter who I will introduce when we see her here. And if not, we'll be sure to get you access to her presentation. But for now, please, let's give it up in reactions, if you will. Show Amy some love in your reactions. Come on, let's use those reactions, everybody. So without further ado, Amy, please.
All right, thank you. So my name is Amy Griffin. I work and live in the Washington, D.C. area. As Patrick said, I've worked since 1991 to assist low-income individuals with HIV to achieve positive health outcomes. I started at 10 years old, as you can see. Currently, I work in the Ryan White HIV/AIDS program, but I've bounced back and forth in my career between HIV housing programs and HIV healthcare. So this is my wheelhouse. I love talking about the intersect between HIV, healthcare, and housing. And before we move to the next slide, I do want to point out that on this slide, we talk about the Ryan White HIV/AIDS program, but we do use the acronym RWHAP. I will use that throughout the presentation. Otherwise, there'd be 102 slides. So next slide, Patrick. So my goal for today is to provide you some information about why the Ryan White HIV/AIDS program decided at the federal level to focus on housing as an important healthcare intervention. Our program has for many, many years incorporated housing into the way we do business. For HIV prevention providers, while I understand housing is a hot topic, I think the role of HIV prevention providers in providing housing is a much newer conversation. So I thought I would talk to you today about why and how we got involved. And to that end, I want to give you an overview of the Ryan White HIV/AIDS program, kind of level set where we are. Show you some data leading to why we invested in housing, talk to you about some of the ways our program has supported housing, and then give you a couple of ideas about how you might consider investing in housing and developing collaborations to address the housing needs of the people you work with. Next slide. So first, an overview of our program. Oh, okay, there we are. So the Ryan White HIV/AIDS program is administered within the Health Resources and Service Administration, or HRSA. HRSA is primarily a grant and cooperative agreement-making agency. We support more than 90 programs that provide healthcare to people who are geographically isolated, economically or medically challenged. We have over 3,000 awardees that include a range of organizations from community and faith-based organizations to colleges, governmental agencies, and private entities. We serve tens of millions of people, including pregnant people, families, people with HIV, and those who would be otherwise unable to access healthcare. Next slide. Within HRSA, the HIV/AIDS Bureau, or HAB, administers the Ryan White HIV/AIDS program. And as of 2019, the Ending the HIV Epidemic in the US, or EHE initiative. On this slide, you will see our mission and vision. We actually refreshed our vision and mission in 2021 to address the rapid changes in healthcare and the EHE initiative, as well as the release of the National HIV/AIDS Strategy. The update ensures our mission and vision are forward-looking and acknowledge the ultimate goal of ending the epidemic in the US and what HAB needs to help us get there while continuing to provide high-quality HIV care through our Ryan White program. So next slide. So the Ryan White program where I work provides a comprehensive system of HIV primary medical care, medications, and essential support services for low-income people with HIV. We fund states, cities, counties, and community-based organizations. More than half of the people diagnosed with HIV in the US receive some sort of HIV care and treatment service through the Ryan White program, which is a pretty spectacular number. The key feature of our program is that based on data, local need, and planning processes, recipients get to determine which services to fund. HRSA provides sort of a menu of allowable services, and then the recipients choose from that menu. This is important for you to know because as we talk about housing, some jurisdictions fund it and some do not. And where they do fund it, the program design may look vastly different. So it gives our providers sort of flexibility to think about how housing needs to be provided in conjunction with their local partners. The Ryan White HIV/AIDS program must be the payer of last resort, which means that if any service is allowable through insurance, Medicaid, or Medicare, it should be billed there before it's billed to us. And 89.7% of Ryan White clients were virally suppressed in 2021. So viral suppression is when the virus level in a person's blood is low enough that they cannot pass it on through sex. It is a key marker both in terms of HIV care and prevention. So it's a term you may be familiar with. What we know is that if a person diagnosed with HIV receives services in the Ryan White HIV/AIDS program, the high-level medical care and importantly, the wraparound services that we provide prove to be remarkably effective. And I just want you to think about that. Of the people who receive services from us, 90% are virally suppressed, which is an amazing number. And that is primarily due to the work that happens at the state, local, and organizational levels. Next slide. So this slide gives us a little bit of information about who we serve. So of the total number of Ryan White clients, and that was 567,803 in 2021, nearly 3/4 are from racial ethnic minority populations. Nearly 2/3 are living at or below 100% of the federal poverty level. I do want to note here that the percentage of people at or below the FPL differs by race and ethnicity. So for example, 67.8% of people who identified as Native Indian Alaska Natives, 64% of people who identified as Black African American, and 61.6% of people who identified as Hispanic were living at or below 100% of the FPL. More than 80% of the people in our program have some form of insurance. And finally, the Ryan White population is aging. In 2017, 29.4% identified as being aged 55 years or older. In 2021, this number increased to 35.8%, with nearly 1/3 identifying as over age 65. Next slide. So now I want to talk to you about why housing services. So next slide. Because our providers are not housing providers, we really needed to figure out first what the role of the Ryan White program should be in addressing the housing needs of persons with HIV. Why should we focus on housing as a healthcare intervention? I'm sure that as you listen to this presentation, you may be asking yourself some of the same questions. Is it your role as an HIV prevention provider to address the housing needs of the persons that you serve? For us, the answer was essentially born out of research and our own data within the program that show unstable housing has a direct impact on viral suppression rates. And there are also studies that show that it is a more significant indicator of poor HIV health outcomes than behavioral health issues, although certainly there's an overlap and that people with behavioral health issues are more likely to identify their housing status as unstable. Additionally, unstable housing disproportionately affects the priority populations identified through data in the National HIV/AIDS Strategy as those groups we want to focus on. So in many ways, we cannot end the HIV epidemic without addressing the needs of people experiencing unstable housing and homelessness. Next slide. So over the next couple of slides, I'm going to show you some of the numbers from our program. This data set is from calendar year 2021. And these data are why we started down the role of housing. It's because our data told us that we need to. This data comes from our annual client level data report, which is a summary of client level data provided by every Ryan White funded agency. So they just submitted 2022 data. We won't have that till late next year. So again, we'll be presenting 2021. And just to sort of level set, we define housing status in our program in the following way. Unstable housing, which includes emergency shelters or public or private places that are not designed for or ordinarily used as a regular sleeping accommodation, jails, prisons, or juvenile detention facilities, hotel or motels that are paid with emergency shelter vouchers, meaning that it's paid by an agency. Temporary housing is really defined as a place where a client cannot be permanently. This could include transitional housing for people experiencing homelessness, staying with family or friends, something like that. And then stable housing, which is home or apartment that people live, but it could also be a subsidized unit as long as it's subsidized on a long-term basis. So in 2021, of the clients who had reporting housing status, 6.6% had temporary housing and 5% had unstable housing. And I want to note that for the rest of the data, these they include Guam, Puerto Rico, and the US Virgin Islands as well. Next slide. So the Ryan White program data tells us that those populations identified in the National HIV/AIDS strategy as needing tailored and impactful HIV prevention and care services are also those communities disproportionately impacted by unstable housing. So in the previous slide, I noted that for all clients where housing status was reported, 6.6% identified as having temporary housing and 5% identified as having unstable housing. Note here the much higher percentages of temporary and unstable housing for youth aged 13 to 24 years old, people who identified their HIV transmission category as injection drug use, and transgender people. Next slide. So I'm going to switch gears a little bit. And now that we've covered the extent of unstable housing and who it affects in our client population, I want to highlight how that unstable housing affects viral suppression among our clients. And just to remind you that this is a key HIV treatment and prevention marker for public health. While viral suppression rate, so the left-hand side of your slide is 2010. This is longitudinal data across to 2021. While the viral suppression rates for all people at all housing statuses increased within those 11 years, clients served by our program with temporary or unstable housing continue to have lower viral suppression rates. Next slide. So this chart's a little busy. I'm going to explain it to you, but it shows viral suppression rate among our priority population served in the Ryan White program. It shows a side-by-side comparison of viral suppression for each population in 2010, which is indicated by the dark gray bars, the lower ones, and in 2021 indicated by the light gray bars. For comparison, viral suppression for the entire Ryan White population are indicated by dotted lines. The lower dotted line, which is dark gray, represents 2010. Our average viral suppression rate then was 69.5%. The dotted line at the top of your screen represents the data from 2021, and it shows an average viral suppression rate of 89.7%. It's a pretty remarkable increase over the last 11 years, and it continues across all of our key populations. However, I do want to point out that there are challenges that remain in achieving viral suppression for certain populations in our care. Most notably in 2021, the client subpopulations with the lowest viral suppression rates were people with injection drug use, Black African Americans, transgender clients, youth aged 13 to 24, and clients with unstable housing. And for the last several years, clients with unstable housing have continued to have the lowest viral suppression rate of those groups that we study. Next slide. So on this slide, I want to focus on the light gray bars on the right side. This shows the viral suppression rates for populations of people identified in the National HIV/AIDS strategy as priority populations when they are also experiencing unstable housing. What you will notice here is that the viral suppression rates for all people with unstable housing, that's shown on the left, it's the lowest bar on the left-hand side of your screen, shows a viral suppression rate of 77.3%. But for people who identify as transgender, who are youth aged 13 to 24 years old, or who have HIV attributed to injection drug use, those viral suppression rates are even lower than that 77.3%. So you'll see for people who are in multiple categories that we study, that those disparities are even greater. So next slide. Oh, there we are. So recognizing that the data clearly shows an intersect between housing and HIV health outcomes, HRSA has made significant efforts over the years to incorporate housing into our policy work, our program design, and our demonstration projects. And our demonstration projects are where we really look at emerging trends in service delivery and evaluate them to see if it's something that we should be replicating across the country. Much of this work involves ongoing collaboration with the U.S. Department of Housing and Urban Development, or HUD's Office of HIV Housing. They are the office which administers the HOPWA program that we discussed earlier. We also do a lot of collaborative work with the CDC as well around housing. Next slide. So I don't intend to spend a lot of time on this slide. The takeaway is that HRSA recognizes the importance of incorporating housing as part of a whole person in their care in Ryan White, and has consistently made changes to our federal policy to try and increase flexibility for recipients that need to address the care of unstably housed clients. All of these changes were made because we heard from our recipients and after engaging with our partners to make sure that we were complementing each other's services and not supplanting them. Most recently, the CDC HRSA Advisory Committee on HIV, viral hepatitis, and STD prevention and treatment held a panel discussion during its November 2021 meeting to hear insights from CDC and other jurisdictions responding to HIV outbreaks among people who inject drugs, in which unstable housing was a common issue, and highlighted opportunities for collaboration with the HOPWA program and other programs administered by HUD. Next slide. Additionally, on the policy front, HRSA has committed to exploring the issues surrounding the housing needs of people with HIV. We have convened 2 housing technical expert panels, or what we call TEP because, not enough acronyms, consisting of people with lived experience, HIV care and treatment providers, housing providers, technical assistance providers, and advocates. And the goal was to define the issues our clients experience related to housing and to hear about facilitators and barriers to housing access. Our first was in November 2019. We convened a 1-day TEP to discuss the housing needs of people with HIV who are in our program. On this slide is a link to a white paper that was created as a result of that. I encourage you to look at it if you have an opportunity. It outlines some of the key issues facing our clients and as well as our systems of care. And just this past August 2022, HRSA, HUD, and CDC conducted a second TEP to focus on the barriers and system drivers that hinder or help people to access HUD's broader programs beyond just HOPWA. This TEP explored collaborations that support a status-neutral approach to housing. For those of you not yet familiar with the term status neutral, it means that following an HIV test, the person is either supported to stay HIV negative through prevention programming, or they're provided HIV care and treatment, which would include services offered both through Ryan White and through the HOPWA program. Next slide. So although the primary mission of the Ryan White program is to support the healthcare needs of people with HIV, it does allow for some provision of housing. So we actually allow our providers to choose to fund some housing supports. And to maximize the reach of these programs, HRSA collaborated with HUD, and our programs, again, are sort of to fill gaps until we can get clients onto longer-term programs offered through HUD. Ryan White uses something called policy clarification notices, or PCNs, to formalize programmatic policy. PCN 1602, which is entitled Ryan White Services, Eligible Individuals, and Allowable Uses of Funds, defines the menu of services from which our recipients can choose to fund services. One of the categories in PCN 1602 is called housing services. It's defined as transitional, short-term, or emergency housing assistance to enable a client or a family to gain or maintain outpatient ambulatory health services and treatment. It includes temporary assistance necessary to prevent homelessness and to gain or maintain access to medical care. You can see on the slide that we do have some parameters set around that, but the takeaway here is that given the data and the flexibility in our legislation, we do allow our providers to fund housing as a way to transition a person into more permanent options and to support their retention in HIV primary care. It is worth noting here that our services do work best when the client is surrounded with other services based on an individual tailored service plan. Next slide. So another service category in PCN 1602 is one we call emergency financial assistance, or EFA. And EFA provides a limited one-time or short-term payment to assist a client with an urgent need for essential items. And this can include things like utility payments, past due rent, food, including groceries, as well as food vouchers, transportation, and or medication that isn't covered by other programs. The difference between our EFA program and the housing services program is really how long the person needs assistance. Housing services is really a temporary kind of assistance, where EFA is more a one-shot deal where a one-time payment would help stabilize that client. And it's worth noting that none of our programs actually allow direct cash payments to clients. So these programs pay landlords directly or utility companies directly. Next slide. While the Ryan White program allows programs to pay for these types of housing, people experiencing unstable housing or homeless need to be surrounded with a whole host of services in order to improve their access to medical care, increase their retention in care, promote independence, and ultimately to improve their viral suppression rate. A holistic care model may include some of the services listed on the slide, and they include things like case management, peer navigators, which we love peer navigators. Our data is continuing to show that people learn by example, and that peer navigators are better at reaching people and getting people into care and into services. Next slide. So our providers have developed a number of strategies to address the housing needs of people experiencing homelessness, as well as improved medical care for people experiencing housing crisis. And I just want to point out the difference. One is providing housing, and the other is looking at the unique medical needs of people with HIV who are living homeless or are living without or living in housing crisis. This slide includes some examples of unique ways our recipients are implementing programs. But in the interest of time, I'm going to highlight just a few. The first and most obvious is that there are programs that exist within housing facilities. And in this model, the provider is located at the point of where people seek assistance with housing. We're also seeing an increase in providers offering HIV testing, linkage, and medical care through mobile outreach services. There are some, for example, that created relationships to provide testing and medical care within existing mobile outreach programs that offer things like clothing, food, showers to people who are living homeless. And in some cases, tailoring those services very directly for priority populations. There are examples that we see of programs that are really looking into their data and are looking to see who's most likely to be diagnosed with HIV, who's less likely to achieve viral suppression after receiving an HIV diagnosis. And so we've seen programs, for example, that support youth services that allow youth a safe community to hang out, to learn about HIV, to get HIV testing. And then if they do test positive at some point for HIV, they can have access to referral services and mental health. They may have access to employment services and housing, all within the context of HIV medical care as well. There are organizations specifically that are doing street medicine that are also tailored towards specific populations. For example, trans women living homeless. That's one that we're seeing out in California, actually. On the administration side, we've seen some state and local government agencies create joint requests for proposals, or RFPs, that address housing and HIV prevention as well as care services. And what they've done to promote that is they look at the sort of the legislative requirements of these programs, and they align them at the government, at the state government agency, so that providers who have reach into client populations don't have to think about that and coordinate all of that at one time, and are able to just deliver a holistic service or a status neutral service. Next slide, please. So the Special Projects of National Significance, or SPINS program, supports the development of innovative models of HIV care and treatment in order to quickly respond to the emerging needs of clients in our program. SPINS advances knowledge and skills in the delivery of HIV healthcare and support services to underserved populations. Over the years, we've had a number of SPINS projects that supported models related to HIV housing and the impact of housing on HIV health outcomes. You can see a number of them on the slide. I wanted to point you to the last bullet before it says resources. You can see that we have a new project that's just in the beginning stages of implementation. The purpose of what we call the SURE Housing Initiative is to look at implementation science. What does it take to implement and adapt housing-related intervention strategies for 3 priority populations of people with HIV who are experiencing unstable housing and who have the highest rates of HIV health disparity? At the bottom of this slide, you can see, sorry, talking off script, Patrick. At the bottom of this slide, you can see resources. I encourage you to look at those, that resources. One of the outputs of the SPINS project are often curriculums and trainings, ways that people implement and what it takes to implement these services. So that's a great resource if you want to take a look at it. Next slide. So building on the policy program and SPINS demonstration projects I discussed, I want to leave you with what it might look like and what you might need to think about to develop status neutral HIV prevention and housing services. In January 2023, HRSA and CDC published a joint program letter to encourage the development of status neutral programming. In that letter, status neutral services were defined as a syndemic approach to public health, weaving together resources from across infectious disease areas and incorporating social determinants of health to deliver whole person care regardless of a person's HIV status. So in thinking about this presentation, I wanted to kind of leave you with a framework of things that you might need to think about to integrate, to start thinking about and implementing a status neutral approach to housing. So the first is, what does your data say? Look at your data to understand where to focus HIV prevention activities to achieve the greatest impact. And this is a question I've heard. Status neutral housing is not just housing for everyone who does not have an HIV diagnosis. And I've actually been asked that question. If they're not HIV positive, isn't it everybody else who's low income? It's about designing housing that achieves maximum impact for those groups who are more likely to be exposed to HIV and to have poor health outcomes once diagnosed. So, for example, people who inject drugs, you may have a housing program specifically targeting or prioritizing is a better word, people who are experiencing injection drug use. Next, talk to your communities. What services are needed to decrease HIV infections in those populations that you identified in your data as most needed? So as public health providers, we have the data that shows us who might need those services, but go into your community and ask people what they need. The qualitative data is out in community. So once you join that quantitative and qualitative data, what kind of housing do you need to move that needle for the groups of people that you're serving? Number 3 is, what collaborations do you need? Can you reach out to housing providers in your area to create unique collaborations? Be prepared to talk about the win-win. You most likely work within the same communities as the people you're trying to work with. What can you offer them and what do you need? Do they need to access testing? Do they need to share data with you? What kinds of things can you work together on? Remember, relationships take time and effort. In my experience, sometimes it takes a dedicated staff person and someone with dedicated time to create those relationships. Don't just stop at an email that's not responded to. Number 4, start small. You will not, nor should you think that you're going to solve the housing crisis in your community, especially out in California. Start small. Use data to evaluate and tweak your programs. And finally, share your successes. Status neutral housing is an emerging idea. Learn from each other and steal ideas shamelessly. Next slide. So this is me. If you have a question, that's my contact information. And I think the last slide is around how to contact HRSA. So if you have a question, if you have a question about HRSA, you can follow us on social media. You can go to our website. You can sign up for e-newsletters. And now I see Christina. Yay. So I'm turning the presentation over to Christina Santana.
Great. Thank you, Amy, for that very, very thorough overview of the issue of housing and HRSA's response to it. And I just want to take a minute before Christina comes on. In chat, several priority populations were mentioned as being disproportionately impacted by unstable housing. So in chat, what are some of the populations that you can remember that Amy just talked about, or populations that you're working with who are impacted by unstable housing? If you would put that in chat, that would be great. And for example, I was struck by, not surprisingly, but still that 2/3 of people experiencing unstable housing are living in poverty. That's kind of a no-brainer, right? But that's something to consider in our programs. So in chat, what other populations are you either working with or did Amy mention as being disproportionately impacted by housing? I know it was a lot of information, so use that chat button. I'm not seeing anything yet, and Greg's going to help me with chat. So people who inject drugs and youth, populations transitioning from incarceration. Yeah, that's some of the populations that you're working with. Others, transgender persons, youth and young adults. Yeah. I mean, it's a really, really big issue. Thank you for those of you who placed that in chat. It's a big issue. And I think there's some things that I wanted to mention is that, you know, what often comes up is the need for additional funding or being able to lift restrictions on funding. So think about, when you're thinking about your partnerships, think about HRSA as an important partner. And remember, I don't know about you, but I heard some funding that might be available that you can tap into to add housing to your list of services. So without further ado, hello, Christina Santana. How are you?
Hello, I'm good, thank you.
And I'm going to introduce Christina as soon as I find I just had it up here and I clicked on the wrong button and lost it, but I want to let you know who is talking to us about this. Whoops. So, well, I'll tell you what, Christina, in the interest of time, I apologize. Please tell us who you are and let us know who you are.
Yeah, no problem. Thank you, Patrick, for the invitation to talk today. And thank you, Amy, for setting up such a wealth of information around housing, particularly within the Ryan White program. So my name is Christina Santana. I'm a senior manager at NASDAD. For those unfamiliar with NASDAD, if you could go to the next slide. We are a national nonprofit organization that focuses on membership of the HIV/AIDS divisions of the health departments within the United States and U.S. territories. Our mission is to advance the health and dignity of people living with and impacted by HIV/AIDS, viral hepatitis, and intersecting epidemics by strengthening governmental public health and leveraging community partnerships. So what that means essentially is that we work across HIV prevention, care, hepatitis, health equity. And as we know, as we are, working on ending the HIV epidemics, integrated planning, STI national plans, we know that there's this concerted effort to really focus on not just the medical needs that the communities we serve are facing and trying to address, but also the non-medical needs. And with that, Amy set it up perfectly when we're talking about status neutral HIV prevention and care. What we're really doing is it's a new approach at looking at individuals holistically. So this approach was really pioneered by the New York City Department of Mental Health and Hygiene. And it's looking at a pathway in how clients engage, how communities engage with providers, with systems, and how we can, again, treat them holistically to recognize that they are interacting in and out based on their day-to-day conditions. So essentially, this figure shows when an individual comes in and they receive an HIV test, we treat the process as cyclical. So they may enter, depending on the results of that test, would determine their pathway. Regardless of the pathway, the point is to ensure that a person is receiving quality care, that the care is really focused on being culturally inclusive and responsive. So, if a person, once they get a test, if the test ends up being negative, they cycle through and they are able to interact with providers along that pathway, whether it's, to get PrEP support, education, condom usage, harm reduction, all of the typical things we think about within prevention, skills, tools, strategies, things like that. And then on the care side, if their test ends up being positive, they would cycle through and go through the treatment pathway. And again, it's really focused on the quality of care. So not just looking at, the care continuum as we traditionally thinking about it, but thinking about the things in between the care continuum that impact an individual's ability to reach vital suppression. So next slide, please. On an individual level, what this really means is that we are looking at the medical and psychosocial needs of individuals. So it's not just the traditional HIV, things like lab testing or provider primary care, but looking at things that are impacting the individual on a day-to-day level. So that could be housing, food assistance, transportation, income, employment, substance use, or insurance and entitlement. And it's really thinking about the impact of each of those things as they are moving through the various continuums. So whether it's the HIV prevention continuum or the care continuum. So what is the impact and how does it ebb and flow for an individual? We know sometimes, certain points in life, things can get harder, things can get easier depending on what is happening. So on an individual level, it's about thinking about the day-to-day pieces that are impacting their ability to reach a quality of health. Next slide, please. On a community level, it is taking those same factors and really thinking about it, again, from a community perspective. So not just housing so if we were looking at housing and individuals' housing stability or not, it's looking at what is the community housing situation. So, are the neighborhoods safe? Do they have things like access to transportation? Do they have sidewalks? Is rent reasonable? Are individuals able to feel like a community sense in there? And you can apply that to all of the different aspects of social determinants of health. So again, it's about moving up from the level of individual, but looking at the community itself. Next slide, please. So overall, when we're talking about a status neutral program, these are the things that we want to make sure are the pillars of a status neutral program. Again, it treats the whole person. It is culturally affirming. It is inclusive. It works to reduce stigma. It is trauma informed. And again, addresses social determinants of health. So all of this kind of seems intuitive, especially given where we've been moving as a field over the last couple of years. But it's really important as we are moving forward with, creating status neutral framework within our programming, that we are really intentional and thoughtful about how we are addressing each of these elements of a status neutral program. Next slide, please. So I have two examples from two jurisdictions that are kind of leading the work around HIV housing under prevention. So as many of you may be aware, there currently isn't a way, or there's no funding or no program that supports housing services under CDC funding or pretty much any prevention funding on a federal level. So the first example I have is from Chicago, and they were really one of the first jurisdictions to really see how they could create a HIV housing prevention program for people who are not HIV positive, but may be vulnerable or at risk of HIV. And so the Chicago Hope program has been around for, I think, about 2 to 3 years. And that began really as a partnership between the housing and the PrEP linkage to care team and program. So the way that they have structured it is they work with community CBOs or, CBOs, and they provide subaward funding to them to essentially build certain housing programs or services linked to PrEP usage and maintenance. And each program proposed their own structure. So the Chicago Department of Public Health released the parameters in which they had to build the program. And then each of the community organizations applied and set and shared how they would build their program within those certain parameters. And so they each address different communities. So one is addressing people who use drugs, another is for young Black men, another is, I believe, for trans women, and I believe there's one other, but I apologize, I'm forgetting the community that they're focused on. And basically, this is providing permanent supportive housing within subsidized rental units for those community members, for those individuals. The requirement is that they are on and adhere to PrEP. And then there's other services that are also provided, or they're connected to other services, I should say. So within this program, there are 3 levels. Really looking at housing assistance. For most of them, it's looking at housing assistance for different communities. I'm sorry, there's a typo on the screen. But there's also scattered site housing, bridge units, and again, just plain rental assistance. So it varies. This program has been really successful so far. If I remember correctly, they within the years that it's been released, they haven't had anyone seroconvert, and that they've been able to really see growth and opportunities come to individuals who are engaged in this program. I should also mention that the funding that they're using for this is coming from their state dollars. However, they're hoping to transition some of their funding support to EHE or from EHE funds. Next slide. The next one is the Washington, D.C. Status Neutral Housing Program. I won't go into the video too long because I know we're at time and I want to be mindful of people's time. However, this program has also created a connection between PrEP utilization and housing support for people who are HIV negative. So again, it takes a status neutral approach and is looking at individuals who are connected to PrEP and getting them into housing. This particular program is specific to young adult men of color. So I believe they're looking at ages 20 to 30, I believe. I have to verify that. But they are, again, similar to Chicago, are looking at the utilization and adherence to PrEP in order to support housing support services. And with this, they are also creating access to other services. So this is the link in the video is in the slide. I encourage you all to watch it.
And Christina, I want to interject. We do have time to show the video. It's not very long. And so, okay. Yeah. You want to go ahead and do that?
Yeah.
Okay, let's do it. Let's do it. Let's see if we can do this. Here we go. All right.
Hello, my name is Anthony Fox. I serve as the Division Chief for the Capacity Building, Housing, and Community Partnerships Division here at the DC Department of Health, HIV, AIDS, Hepatitis, STD, and TB Administration.
My name is Chantel Thomas. I have been in the field for 17 years, and currently I'm the Housing and Equity Coordinator for DC Health HOSTA.
So the interesting thing about the DC area, which we call the DMV, which is District, Maryland, and Virginia, the problem is that the cost of housing in these areas are extremely high. DC is 5th in the nation for the highest cost of living. Maryland is 9th, and Virginia is 14th. That's the issue that we run into as a provider. And just think about what that does to a client who's trying to maintain their health and also to stay healthy. We are part of the Interagency Council on Homelessness, which, most of our service providers who do housing related services are part of that. We have sister agencies that we work with, and we are in the process of creating a task force from all of these sister agencies to really look at how do we do better at collaborating around the housing needs of individuals within the district. We have really sought to create an integrated plan that addresses not only the care and treatment of a person who's living with HIV, but we've also begun to look at how do we address their prevention needs, those persons who may be at high risk for acquiring HIV. And so our integration has really moved to the next level in looking at PrEP and PEP and some of the other biomedical and or structural interventions around prevention that we can look at to support with housing related services and housing needs of individuals.
We provide single room occupancy, a transition style housing for young men who have sex with men, ages 24 to 35 for a period of 18 to 24 months. Clients don't have to pay any rent. We encourage them to save about 30% of their income so that at the end of the program, they're able to transition to a more stable housing setting, independent of services that we have been providing. We also make sure that we speak to the whole person, providing coordinated clinical care for PrEP at low or no cost to the client, linking them to services such as Medicaid, or if they're working, making sure they have the best commercial insurance plan that will cover their PrEP, making sure that we cover transportation, offering food assistance through a stipend as well. One of the biggest things that I see that has been a success in our case management piece is linkage to workforce development. We know that when people have income, they have more stable outcomes, and they're able to navigate spaces that they were not able to navigate before, such as independent housing. How can we, foster efforts around these various, things or variables that ensure that a client will have a successful chance of living independently, once they exit the program, be it workforce development, school, are they connected to other support and direct services? Are we connecting them to other housing programs and not just sending them in a loop?
Allow space for creativity and innovation. The great programs that we now here at DC Health are able to do were created by a lot of the staff that have been part of the programs. And I think for me, that's the best practice that you can put into play.
Service the whole client, bringing non-traditional partners to the table so that you can speak to the need of that client. Where the client is, that's where you want to be.
Thank you, Patrick. So as you can see from that video, they really have taken an approach to really look at the community as a whole as they were building this program. And one other thing I'll note with that program in particular before I wrap up is that unlike many other jurisdictions, DC Health did a lot of work to integrate their housing right directly into DC Health programming and department. So for a lot of jurisdictions, housing and housing support sits outside of the health department. Again, DC Health did a lot of work to integrate that into the health department. So I'm happy to answer any questions. Reach out to me. There's my email address. I'm also happy to connect you with peers, and I hope that this has been helpful.
It's been very helpful. Thank you. Thank you, Christina Santana. Let's give Christina some love. You can use your reactions button if you're Zoom savvy. And thank you to Amy for that excellent overview of the issue of housing and what some agencies are doing to address it. And I'll save the rest of my comments, but what questions and comments does anybody have? You can put it in chat or you can come off mute. We encourage you to show yourselves. Don't be shy. We're a loving family here. Show yourselves and any questions for Amy or Christina? Robert.
Hello, good morning, good afternoon, depending on where you are. Thanks so much for these presentations. I guess I'm asking for you all to maybe comment on what I'm about to say. I'm worried about congenital syphilis. And that intersects with prenatal care. And I fear that when we talk, we say things like holistic approach and treat the whole person and so forth, but there's still somehow the topic of STDs left out of this conversation. And I fear it goes back to that age-old thing where the STI and the HIV people don't talk to each other, rather than putting us all under the sexual health umbrella. So I wonder if you have a reaction to that, how funding affects this, and if anybody else is also worried about congenital syphilis in this population of vulnerable people.
So Amy or Christina, would you like to comment on that?
Do you want to tackle it, Christina?
I was just going to say, I appreciate the question, and absolutely. I know from conversations we've had with other jurisdictions, this is also a concern for them as well. Speaking in terms of, what's happening at NASDAD, when that's one of the messages that we're really trying to push with our members and with different staff across the United States, just in terms of when we're talking about treating holistically, we have to move beyond this idea of holistic within the umbrella of HIV. It has to be inclusive of the other STIs, as well as, the other syndemics that, folks are facing, because we have lofty goals within each of the different plans, whether it's integrated planning, EHE, the STI national plan, but it doesn't make sense to achieve any of those plans if we're not having open dialogue, communication with our colleagues in different topic areas. We at NESED are trying to work closely with NCSD, or the National Council, I believe, of STD directors, to, keep promoting this idea of, cross collaboration, cross communication. So I know it doesn't necessarily, it doesn't scream innovative or forward, thinking, but, I think a lot of what we've done in the field has been through continued communication and advocacy. And I know that's an approach that we're continuing to promote.
Great. Amy.
I would say that, some of that siloing happens naturally because of funding streams, and that, part of what the National HIV/AIDS strategy, and when we talk about status neutral approaches, is about, from my perspective on the federal level, making sure that we're talking and sending those messages down around, you may be funded separately through these different streams of funding, but you do need to communicate and talk in the ways that Christina's saying. I think you see that in the National HIV/AIDS strategy around a syndemic approach. Also, I will say my leadership was involved in the National STI planning. I think there's cross-pollination at the federal level around that and how people work together. We're starting, my day job, my bread and butter job is in the ending the HIV epidemic part of Ryan White. And we're starting to see some of that programming around integrating HIV care and STI and HIV prevention at that level as well. I think it's important in venues like this for people like you to also keep bringing it up, because there's all the different levels, right? There's the federal level at which some of that conversation is happening. There's the state and local level. There's, Christina comes at it from a different perspective as a technical assistance and advocacy provider. We all have a role in that work, and we all need to make sure that conversation continues so that we can see it sort of translated in how we work with clients.
Thank you. An excellent comment, Robert, and question. Other comments and questions? I think,
Sorry, can I just add one thing?
Sure.
I think this also goes, and again, I'm talking about some from an idealistic point of view, I suppose, but some of it goes to the training that we provide our outreach workers and so forth. For the longest time, we haven't trained our staff who work with people who use and inject drugs in providing any kind of sexual health information or triage to the clients that they see. And while there's not a lot of solid data, for instance, I think a lot of people believe that more new HIV infections happen through sexual transmission among people who use and inject drugs than with sharing needles. And so I think another part of it is it's again, it's like integrating all of these worlds so that we can reach this holistic approach.
Thank you. And what's resonating for me, and hopefully it's we're all thinking about this, is the need to bring all of those voices, to ensure that the voices representing these other issues are at our table. And so when you think about some of the other partners, be thinking and be ensuring that you have STIs at your table, not STIs at your table, but somebody representing services provided to people at risk or dealing with STIs. Make sure that you have them at your table. The other thing that I think is really building nicely upon the last session, where Joel was talking about data, is the need to ensure that we're collecting all of this data, the need to ensure that we're able to show quantitatively and qualitatively, but quantitatively in particular, the overlap. I mean, it's not new to those of us in the field, but to outside partners, it could be new. So those are some of the things that I think about when, I think about how, also I want to say, I just came back from an Ending the HIV Epidemic meeting that NASDAQ hosted for the Western region in Phoenix. And one of the things that came up resoundingly was funding and funding restrictions. And how can we think creatively to overcome some of those restrictions? We are unfortunately still dealing with silos. We have been from the very beginning of the epidemic. But how can we think of structural interventions that can overcome and rebuild those silos, or tear them down, or whatever we have to do? So our work, is cut out for us. And I also just wanted to say that hopefully you're able to see how these social determinants of health are overlapping. Yeah, many of the times we're dealing with the same populations of people who are disproportionately impacted by all of this. And they're also disproportionately impacted by things like you heard in the video, employment, or unemployment, a lack of education, lack of access to services. And so all of these social determinants, that's really what we're talking about when we talk about addressing social determinants of health, is how can we alleviate some of those barriers that clients are facing? And how can we think about coming from a holistic standpoint, where we're addressing not only the disease, but really what's at the root of the disease. And we're talking about things like employment and things like education, workforce development came out. So we're on track. I feel like we are responding within the guidelines of the Ending the HIV Epidemic. Amy.
I just wanted to point out, and I think this has been a focus for HRSA, newish, but along with the Ending the HIV Epidemic, we're very steeped in data. I mean, even in this presentation, presenting why we think about housing as a healthcare intervention, I think where we've been pushing is on more the qualitative data side. So as a health department, as an organization, you have the surveillance data, right? Or you can get it from the state. That, along the lines that I've presented, that those populations identified as prioritized in the National HIV/AIDS strategy are the ones that are most likely to be unstably housed and the most likely to have poor HIV health outcomes. What we cannot tell from that data is, what does that community need? Where are the intersectionality that you're talking about? Because people aren't just one thing. And we talk about youth, but all youth don't need the same thing, right? Or we talk about, Black MSM. You can't put people in a monolith like that. And what it looks like in California and in Colorado may look very different than what it looks like here in the DC area. And so if we don't go out and ask people what they need, we sort of doom our projects in some ways to not be as successful as they can be. And so we've really been encouraging people to go out and talk to people as a health department? What is it that you need? What kind of housing do you need? We talk about housing in a broad sense, but there's all different kinds of housing. What does that look like? How, do people need to pay past due rent? Do they need shelters or emergency vouchers? Do they need temporary housing to transition into a more permanent housing? And I've been spending a lot of time on my EHE side in California. What's needed in California, for example, looks much different than what it looks like on the East Coast. And so I encourage you to go out, and it's time consuming, and, we're talking about funding and capacity and all of those things. But I think that it will help you work smarter in the long run and not, and be able to design programs that are really impactful with the funding that you have.
Thank you. That's a very important reminder. Yes, so I just want to thank you both for taking the time out of your busy schedules, and thank you all, everybody here, for taking the time to join us. In the interest of time, we have a couple questions. We're not going to do a breakout just because we want to get you out of here when we said we would. So I will say thank you to Amy Griffin. Thank you, Christina, for your very important work around this issue of housing. So what we like to do now, what we were going to do in breakouts, I think we're just going to do together. We're an intimate group today, so that will serve us well for this. So either come off, I'd love for you to show yourselves, let's come together. But if you don't want to do that, go ahead and utilize the chat feature. We want to ask you which strategy, or, I won't put it that way, what really resonated with you from today's presentation, or what really hit home, what was something maybe new. And Journey, are you just coming off camera so we can see? We appreciate that. Did you want to comment on anything? Okay, so what resonated? Put it in chat. Like, what's maybe one thing that you will take from the presentation today? What stood out for you? Give you a minute to think about that. So status neutral, Cheryl, thank you. Status neutral approach for housing. Yeah, status neutral, good. So this is new information, Michael, that's great. Yeah, be looking into the status neutral approach, because it's really very interesting, and it really is going to result in some structural changes in many of our programs in order to be able to address status neutral issues. Others, go ahead and put it in chat, or come off mute. And by the way, you can come off mute and not come off camera if you want. We'll accept that as well. And we've got 2 more questions that we want to get to, and then we will end for the day. Anything else that really stood out? Right. I know it was a lot of information, and it's okay if we don't answer all these questions here. I want to remind you that these we are recording, and so these presentations and slides will be available to you after the fact. So you'll be able to go back, because it's overwhelming on some level to think about these huge issues. But you may decide in the future to go revisit this. Prevention, information, and services for people who use drugs, yeah, and people who inject drugs. So thank you, Journey, for sharing that. Let's ask the next question here, and that is, what do you think your jurisdictions need in order to address housing in your programs? And this is an important question for us in particular, but we'd really love to know, what is it that you need in order to think of, if you're not already addressing housing, if you are already addressing housing, what did you need, or what do you need? What do you envision that you might need in order to be able to address housing? Well, unfortunately, we can't do that. I've always told all of my friends and family, you can't live in the past because guess what? It already happened. So we can't do anything about that, at least right now. But yeah, peer advocates. Okay. Joni, did you want to say anything more about that? I think you're in the supportive company, definitely by me, the use of having people who are having lived experience, helping others with that experience. So anything you wanted to add on that? So learning how peers can make a difference. Yeah. Look into peer navigation programs. They're very, very effective. And yes, others. What do you think?
The idea of peer navigation kind of fits in with what Shavar put in the chat as well about what are the resources to get out into the community to hard to reach populations and, get information, find out what they want, find out how to best serve them. And it's both important.
Thank you. Oh, I'm just kidding. Thank you. Thank you. Thank you, Shavar. And you think about doing that in many different ways. I mean, part of what we're talking about there is community engagement around some of these issues. And often, the community is not getting back the results of the data that we collect. So be sure to do that. You can do town halls, you can do focus groups, you can do a number of different community engagement activities to learn from the community and to share with the community. Cheryl is saying to have conversations with our colleagues who are already working with other community partners about housing and find out resources, barriers, certainly, yes. So again, if people from housing are not at your table, definitely get them to the table. And I'll just remind us that these social determinants don't operate independently. And so, last Tuesday, we talked about Department of Transportation. Do we have somebody from Department of Transportation on our HIV planning bodies? Maybe not. And if you don't, think about that, because it's a social determinant of health that is having a direct impact on people's ability to remain HIV negative, or if they are living with HIV, to access services. Another one that came up was Department of Education. Many groups have representatives from there. Department of Labor. I thought that was a good, you can see that hopefully with these sessions, we're trying to build upon the previous session. So, Department of Labor came up when we talked about workforce development. How can we involve the Department of Labor or people who work for various employment industries? How can we get them involved in ending the HIV epidemic with us? All right. And then we're kind of already talking about this. And so you can see, just as these things don't happen independently, neither do our questions. What role or, what internal or external partners do you need to get buy-in from? What role can they play? So I'm thinking about the term non-traditional partners is really being thrown around a lot, but really, what does that mean? And it's going to be different for everybody, depending on where you are, depending on the makeup of your various planning bodies, and depending on the populations that you're serving. So, but we don't really have to answer that right now, but if anybody has a comment about that, internal or external partners, what role can they play? It's such a big question. So I won't belabor that, but I really, really encourage you, when you think about next steps and when you think about putting the information we've received so far in these sessions to work for you, to think about that. Who's not at your table? Who can I partner with that may not be the obvious people? And we've given some examples of that today. So in the interest of time, and this is, by the way, I want to let you know, I'll let you know in just a minute about our next session. We've got 2 more sessions next week as part of this series. But let me put the poll question. So we have now a polling question. How are you feeling after the presentation? And Veronica will put the poll question up in just a minute, but it's the same question. So I can identify 3 actions to address the intersection between housing and healthcare, HIV healthcare. And so go ahead and chat. Come on, everybody, we need your full participation with this one. Come on and let us know. I can identify 3 actions, 3 things, and there were a lot more than 3 that were shared. So come on with it. And I think good. We're almost at 80% there. So yeah, I'm glad to see that. So hopefully this has given you some food for thought. Hopefully this has sparked some new ideas that you can take and put into action. Because we realize that, you know, we've got until 2030. I keep saying, that's my mantra these days. I keep saying we've got until 2030 people. So, you know, how many years do we have left to end this HIV epidemic? And I do believe that we're going to do it. And I'm very excited about it. But these are some of the issues that we need to tackle in order to do that. I want to let you know, thank you for participating today. Next week, and if there are any final questions, just interrupt me. But next week, we have Tim Vincent on Tuesday, who will be joining us to talk about the impact of stigma as a social determinant of health. It's a big one. And some community engagement approaches that we can take in order to begin or to continue to address stigma, so we can get rid of that. It's a big driver of this epidemic. We need to do something about that. Thank you. Veronica put the registration links in chat for the next 2 sessions. And if there are no further questions or